So I work as a kidney specialist, and it's pretty clear that kidney disease is on the radar, and you might be wondering why, what relevance has kidney disease to blood pressure in itself. And we've already heard that one of the signs of organ damage, target organ damage in high blood pressure, is decreased kidney function. And it happens early in life and is a significant problem. And it's a two-way street. The kidneys are probably involved in the handling of salt and lead to high blood pressure, but also if your kidneys aren't working, there's a bit of an issue if you have high blood pressure. So there's been a few of these things on the BBC website saying that people who have kidney disease need better care, and a lot of this will focus on management of lifestyle factors and blood pressure, the two things. So I don't know how much you've followed of the public debate. There's been a lot of I'm a bit square. I do listen to Radio 4, so I didn't want to put my hand up and say I've listened to the Archers. I think Gabriel, and do you remember Jethro? That's going back a bit. But anyway, so there's been a lot of stuff on Radio 4 about overdiagnosis or interesting programs about chronic kidney disease and whether it's overdiagnosed, underdiagnosed. And the figures are pretty difficult to get an exact handle on it. It all happened about 2005 when the way we started measuring kidney function in the labs changed, and that's led to what was called an epidemic of chronic kidney disease, but it was merely identifying that these patients were there and that they have kidney disease by the blood test, which is used to measure kidney function. It doesn't necessarily mean that these people are going to develop kidney failure. It's just another risk factor that needs highlight as part of cardiovascular assessment. So I don't want to send away a message that it is all doom and gloom for your kidneys. It's just another thing that needs attention as part of the global management of somebody's cardiovascular risk. So 5% of people can be labelled as having chronic kidney disease and impairment of kidney function by blood test. Many of these patients will already be known to their GP as they will already have high blood pressure, or they'll be on their GP's radar because they've got diabetes or heart disease. So a lot of this is not screening, it's just being aware of this issue. Kidney disease is also more common in the elderly, so again, a lot of these patients will be on their GP's radar for that. Just to take example, another a disease group which is a big issue, which we've not really drawn too much attention to, but in diabetes, which is the big emerging health problem with the onslaught of obesity. One of the biggest worry for diabetics is that the diabetic involvement of the kidneys is a risk factor for cardiovascular disease. It's one of the earliest signs that your heart is under stress, because whatever's happening inside the blood vessels inside the kidney is invariably causing all the other blood vessels problems. So picking up and detecting kidney disease early in diabetes is a good way of assessing or bettering cardiovascular health, but also it's a better way of managing any risk of further progression of chronic kidney disease as well. So what does a kidney specialist actually do? I look after many of these patients with chronic kidney disease. That's in partnership with their general practitioner. I try and prevent people developing kidney failure, and in patients who develop kidney failure who need dialysis or a kidney transplant, we look after them as well. That's a very small proportion of our workload, although it's the most intensive and hard work, because once you've got kidney failure and need dialysis or transplant, that's a major impact on life, may indeed impact on life expectancy, certainly causes morbidity and lifestyle restrictions and major medication burden. What causes kidney disease in Scotland these days? So these figures come from the Scottish Renal Registry, and it's interesting. This is for renal replacement therapy, people needing dialysis or a transplant. And it used to be that diabetes really wasn't a very common cause of needing renal replacement therapy. Now, part of that was back in the 60s when we'd only just invented dialysis. We, for some reason, didn't think that diabetics would benefit from dialysis treatment, which was just, I say just wrong, but it reflected the infancy of the specialty. Now, actually, for any one single disease, diabetes is probably the commonest cause of end-stage renal failure requiring dialysis or transplant. If we move to the US, where they've got problems with diabetes and obesity, actually 40% of people on dialysis in the US can entirely be described as being on dialysis due to a combination of diabetes and hypertension. So it's a big problem. I'm highlighting all the other things, that there's conditions called glomerulonephritis, inflammation of the kidneys, interstitial diseases, so that might include chronic infections or rarer conditions like sarcoidosis or funny inflammations of the filtering system, of the tubules of the kidney. And a lot of this is unknown. We don't know what's the cause of kidney disease in many patients. We'd like to know more about that. Multi-system diseases are things like lupus nephritis, or people with lupus, or amyloidosis, and people who've got bad rheumatoid arthritis, or many, many other conditions, vasculitis. So what are the risk factors for kidney disease? Diabetes, high blood pressure, I'm sounding a bit like Christian, smoking, obesity, family history, and these other rarer conditions which may put one at risk. So clearly, if these are the risk factors, these are the things that we should be trying to attend to try and minimize one's risk of kidney disease. So, are you at risk of kidney disease? The best way of actually looking to find out are you individually at risk is often filling in this online thing. I did it last night. Unfortunately, I'm still in the clear, but this is a very, very helpful risk factor calculator. And you just type in Kidney Research UK into Google, you get this little link, and it clicks through a few simple questions. Do you have high blood pressure? Are you taking a number of medication? It's very easy to work through. Have you a family history? Has anyone in your family been on dialysis? That type of stuff. And at the end of it, it'll come to you're not at risk, or you probably should have a blood test once a year, and you should make an appointment routinely with your GP to discuss that. Nothing that's going to raise alarm bells, but very sensible, pragmatic advice. If you had kidney disease, so if you're one of the 5% of people whose kidney function has been labelled as abnormal by a blood test, what can we do to reduce the risk of future kidney failure? Treating high blood pressure is the single most important intervention for all patients with chronic kidney disease. There are some specific kidney diseases where there's very specific treatment will be required, and that may indeed be steroid treatment or immunosuppressive drugs in these rarer conditions, but for the majority of people, treating blood pressure is the most important intervention. And if you look at the facts, 65 to 100% of people with kidney problems have high blood pressure, so it's nearly everyone. Reducing salt in the diet is extremely likely to be effective, mainly because it brings blood pressure down. We've got a very active research program just about to kick off about looking at the effect of salt in kidney function. Smoking, not only does smoking increase your risk of cancer and cardiovascular disease, any hardening of the arteries due to smoking will also harden the arteries inside the kidney, and therefore causes problems. There may be more things than that, but suffice to say, smoking is bad. Healthy weight, being obese, puts more pressure on the filtering units of the kidney, causing more protein to leak out of the kidney, causing more damage to the tubules or the bottom part of the filtering units of the kidney, and therefore maintaining a healthy weight is important. I don't think we can be the absolute zealots and say that you should be underweight and jogging, but you certainly should not be very obese. And just to highlight, particularly with respect to hypertension, but also just in general, there's many medicines which you may take over the counter for painkillers or anti-inflammatory drugs will also cause high blood pressure and also may have a risk of long-term kidney damage. Short-term use of these drugs is often fine unless you've got a diagnosed kidney problem. Equally, there may be indications if you've rheumatoid arthritis, you may not be able to do without these medication. But I'm talking about things like ibuprofen, also known as Nurofen, or sold under many brand names, certainly can cause problems with kidney function and may also contribute to high blood pressure as well. This is a analysis, so I'm trying to avoid science as well. But this is just an analysis to show from the MDRD study, which is Modified Diet and Renal Disease. So a big American study which looked at giving people different diets, but also different blood pressure targets in patients with known kidney disease. And suffice to say, the patients with the lowest blood pressure had the lower likelihood of developing kidney failure. I want to make sure these message was that these were patients who already were known to have pretty significant kidney disease and were known to their GP, so as not to raise alarm, or known to their kidney specialist, so as not to raise alarm. But I think it's important to take the take-home message that low blood pressure is an important way of modifying risk of kidney failure. Anyway, so that's kidney disease in general. What's new? So Some of you will have heard of this. Any of you who've spoken to myself or some of my colleagues will know that this is all, I get a lot of discussion about this. There is what's been described in the media as a revolutionary operation that can cure high blood pressure. I really wish they'd never published this story and using these words. It's just, there is a new procedure available which may be a useful therapy for doctors who treat patients with severe high blood pressure. It is a revolutionary new operation, that is true. What the Daily Telegraph have said is that it's a simple procedure in under an hour. Not quite as true. Allows some sufferers to come off medication completely. That is not what we recommend, and not even what the company who invented this device recommend either. It's relatively straightforward and cheap. Well, if you ask your... ain't cheap. Anyway, right, okay. So this is what it is. It's called catheter-based approach for renal denervation. It's called the Simplicity catheter, is the company who are making this version. Other companies are coming along and making them. Maybe a bit of competition in the market might drive prices down, who knows. But this is interesting, and without going too much into the science of it, there are some nerves around the kidney called the sympathetic nervous system, the kind of nerves that are involved in the flight or fight responses, the ones that kind of produce noradrenaline and things like that. And these nerves seem to be implicated in putting blood pressure up. And by using this radio frequency catheter, which is introduced via the femoral artery through the groin, up towards the renal artery, and essentially zapping these nerves with a radio frequency energy along in a kind of spiral technique along the renal artery, it aims to scar these nerves in such a way that it interferes with the processing of these hormones. And in a study of patients with very severe high blood pressure who were taking 3 or more medication and still had a blood pressure at the clinic of greater than 160/90 and were definitely taking their pills, adding this treatment into the mix seemed to reduce blood pressure by 32/12. And this was published in The Lancet in 2009 by the Simplicity investigators. So this was pretty impressive, and this was compared to a control group. Now, in these clinical trials, these patients are very closely watched, and also we don't know that the patients who had the renal denervation, they obviously knew they had the procedure, so there was no placebo, which is what we like to see in trials. And therefore, it may be that this group of patients also decided they behave themselves and take their tablets more, or it may be this effect is completely genuine and it had this major effect. In our hands, we've done a few cases in Glasgow. We've not seen these dramatic responses, but we have seen patients have good responses to treatment. Not all patients, but many. And you'll see, even in this study, which was published with the help of the company, 10% of patients had absolutely no response to this treatment whatsoever. So again, we're moving a bit away from the Daily Telegraph story. Not that anyone in Scotland reads the Daily Telegraph, but anyway, so. Also, this rumour that you came off your medicines. Some patients in the study did. 20% of patients did have a decrease in their medicines. They did not come off their medicine. On average, I think patients in the study were on about four medicines, but they were on between 3 and 7 medicines for blood pressure. So 20% had some reduction in medication. I think 1 or 2 may have come off medicine. So I think it's a bit, it's very early to say that. And some actually had to go more medicine. So here's the practicality of this treatment called renal denervation. Who should have it? I agree that it seems a reasonable thing to consider in people who have poorly controlled blood pressure and 3 or more tablets, who are taking their medicines regularly, although Professor McDonald seems to be interested in some others. So it might be, I think there's an interesting group of patients who have real problems and have genuine allergies or genuine intolerance to lots of medicines. They may also be groups of people who may be of interest of whether this might be worthwhile, but I really think we need to be careful with this, and that would be certainly in discussion with a specialist who knows what who can assess that patient and advise them properly. And again, and same with our children, we need to make sure there's no other cause of high blood pressure, such as a hormone imbalance or even a tumour or an underlying kidney problem, such as renal artery stenosis driving that. Does it work? 80% of people have some reduction in blood pressure in the study, 20% have no effect. but this was in patients who've exhausted options for tablets. Long-term medication is still required, which is not what the media or some patients have been reporting. And that's not, some patients have been referred to us saying, I want to come off all my medicines that are causing me side effects. And I'm really sorry that they're causing side effects. That's something to work through, but we should not be approaching this treatment with the expectation you'll come off medication. You'll only be disappointed, and you'll have had a treatment which is new and with very long-term safety data not available yet. Definite side effects: you get a big whopping great bruise in your groin from the procedure because you've got very high blood pressure inside the artery before the needle goes in, so it's quite likely you'll get a bruise in the groin afterwards. You get pain around the kidneys for a day or two afterwards. Be really quite sore. We obviously give lots of medication to settle that down, but it is sore. The safety data this procedure does seem to be overall pretty safe 2 or 3 years out. Longer term, we just don't know. Is it available in Scotland? And I oblige my colleagues to keep me up to date with what exactly is going on. We in Glasgow have done 14 cases, not funded conventionally through the NHS. The NHS has been very supportive and let us use beds, but we've had to buy the catheters from charitable donations. At the minute, this is being looked at by NHS Scotland for routine use. No decision has been made yet, to the best of my knowledge. Same in NHS England. They are likely to make final recommendations soon. There's various position papers by experts in the field, but no final decision has been made. It is routine in Germany, but that is interesting because the German experience is that the insurance providers have said this is okay, and the radiologists and cardiologists who often perform the procedure get paid for it, so they've over-enthusiastically adopted it. My experience of speaking to people in other European countries is they tend to be using it in similar fashions to yourself in research studies or collecting the data very carefully to see who might benefit and who might not. And in the US, it's not approved yet by the FDA for use in the US, but there's an ongoing large study there. Well, I think that was all I was going to say, so thank you very much.